My name is Brandon Hirsch. I'm an orthopedic spine surgeon at Disc Spine and Sports Center in Newport Beach, California. I'm about 6 years into my practice and was trained on a wide variety of minimally invasive techniques, including MIS TLIF. And over the last 3 to 4 years, I've really transitioned the vast majority of my interbody use through an MIS TLIF approach to using dualX. And I've been very pleased with the outcomes, both radiographically and clinically. So I think as a relatively young surgeon, still plenty to learn and improve upon, but I've had a very strong experience to this point with the implant. And I think there's things that are unique in terms of its expansion, that while there are many expandable implants on the market, dualX really has the ability to expand bidirectionally is really what makes it different, in addition to the overall size of the implant. So I've been fortunate to be able to use a variety of both static and expandable implants through a posterior approach, primarily through a tubular retractor. And although some people debate the utility in the literature of expandable versus static implants, I do think that most surgeons who regularly perform MIS TLIFs recognize the value of an expandable implant. The majority of the implants on the market expand their height, and that's phenomenal for getting press fit on the end plates and for working through a small height annulotomy. But it tends to leave you with a relatively limited footprint. And as we've learned more about the biomechanics of interbody fusion and the relative strength of different portions of the end plate, the field has come to understand that as much as we can do to fill the end plate surface area and to place implants on the ring apophysis where the strongest bone is, that is what is going to protect us against subsidence, and what's going to allow us to maintain the lordosis that we see intraoperatively, in the postoperative period. And that's probably the most challenging aspect of an MIS TLIF operation. If you ask, just about any surgeon, implant placement and disc preparation is the challenge of the procedure, and really can make or break, patient outcomes. And so, great to have an expandable implant that goes from one end plate to the other, but sort of the holy grail, I think, of an expandable implant is an implant that goes in a very small aperture, but you can build to fill the majority of the surface area of the end plate. And I think that's where dualX really stands out. And it's what's been impressive, even though you hear people discuss this implant really has a big footprint. Once you use it and you start to look at your postoperative x-rays, as someone who's done and continues to do a fair amount of anterior surgery with anterior implants, it really is approximating the size of anterior implants. And so that's where I think the big value is, in addition to graft windows and ability to backfill the space and have efficient delivery of the locking mechanism. I think it really, there really isn't another expandable implant on the market that has this complete set of features. There are other implants that are close, but really not at this scale and size. I've been fortunate, in my experience, particularly with dualX, to find that the process is very straightforward. The implant is going to come to you, fully assembled and ready to go on a very easy to use inserter that's also powerful, both in directing the implant and expanding the implant. And so really my experience with this implant has been really minimal hiccups as far as the expansion mechanism and delivering the locking screw. It's actually a very seamless integration of the expansion tool followed by the backfilling tool and integrated funnel, which also is the conduit for the locking screw that sets the locking mechanism. Having experience with the newest generation slim implant really allows us to still achieve the target lordosis, the true lordosis of 8, 12, 15 degrees, but it allows us to still come in at a very low disc height or implant height, 7 or 8 millimeters, which is really pretty rare on the market as far as achieving true lordosis at 8, 12, 15 degrees to fit the end plate anatomy, but that not requiring you to enter the disc space with a very tall implant that's gonna endanger the end plate. So I think the ability to have the newest generation slim design is a pretty significant game changer for really anyone, myself or anyone who looks at a post-operative x-ray of this implant. The size, the end plate coverage is the clear differentiator of this implant. I think probably second and third are going to be the ease of use and expansion and the ability to come in at a 7 or 8 millimeter disc height. So first, just pure size of the implant, ability to select appropriate implant lordosis to fit the level and the target. The biggest game-changing patient is a patient who comes to see me who has a very collapsed L5-S1 level, and perhaps their other levels are compensated. They're not globally malaligned, but it's very obvious that they've lost an exceptional amount of lordosis from disc height loss at L5-S1. This is a patient who traditionally most surgeons may think I need to do an anterior approach on, but either for logistical reasons or for medical reasons, prior laparoscopic inguinal hernia repairs or vascular anatomy can make it impossible for us to even consider an anterior approach. And historically, those cases would make me very concerned. Am I going to get the outcome that I'm looking for with alignment and fusion? And now I have several of those types of patients where I've been able to achieve essentially exactly what I thought I would achieve had I been able to do an anterior approach on that patient. And so those are some very, very happy patients.